Good morning, everybody. Thank you for being here. Today, my name is Alexandre. I'm a member of the PVI social media team, and I have the pleasure of welcoming Dr. Peter Schneider to talk about carotid surgery and stenting. So, hello. Thank you so much for joining us. And for those that don't know you, could you introduce yourself?
Yes, hi, Peter Schneider. I'm a vascular surgeon. Currently, my practice is at University of California, San Francisco. I've had a long-term interest in the technical aspects, both open and endovascular, of all applications of vascular disease management, but especially in things like carotid revascularization. Been involved in a number of the trials, and there have been some new developments that we'd like to talk about today.
Perfect. So you also serve as faculty member for carotid surgery and stenting for the upcoming PVI Congress. And so I would like to start by asking you, in your opinion, what are the indications and the developments in both carotid artery stenting and open surgery?
Yeah, so well, as you know, open surgery has a long time been accepted as our standard therapy for carotid bifurcation disease, but a lot has changed in the recent years. One of the key things is the improvement of best medical management. I think most of us who practice in this area have the impression that best medical management has dramatically improved carotid treatment. Nevertheless, each year, including this year and included in the PVI update book, will be a couple of studies that show the progression or natural history of carotid disease, some of which is at the same time treated with best medical management, but still has a substantial rate of progression or worsening. That's an important thing to know because over the long run, most of the studies that have been done on the history of carotid disease or the value of best medical management has been in patients with mild to moderate carotid disease. But if you follow patients with severe carotid disease, it turns out there is a substantial rate of progression. There was a study this year by Harris. There was another study not too long ago in Lancet Neurology in 2021, also in the PVI book by Howard et al., demonstrating that patients who have 80 to 99% stenosis, a substantial number, approximately 20%, go on to have ipsilateral stroke within 2 years. So this is important because we've talked about how best medical management improves the outlook, and for patients who have carotid disease, they should be on best medical management regardless of severity of disease. But it turns out that best medical management, although valuable for mild and moderate disease, does not halt the progression of severe disease. It might slow it down. Obviously, we're going to learn more in the coming years. You also asked about, so I've talked mostly about best medical. There have been some advancements in both CEA and transfemoral. With regards to CEA, I think it still remains the most important therapy worldwide in most countries with regards to stroke reduction or diminishment of the risk of stroke from carotid bifurcation disease. I do think, though, that the reality is, for example, one of the other studies in the PVI book this year is a pre-planned analysis that looks at CREST, EVA3S, ICSS, SPACE, and it looks at the risk of stroke following CEA and transfemoral. And it turns out that if you normalize, in other words, if you take away the perioperative risk, that all of those, that both transfemoral and CEA in all of those studies, the risk is about the same going forward. So in other words, if you could make transfemoral safe, if you could make transfemoral stent placement safe as CEA in the perioperative period, the stroke risk reduction is quite excellent for both therapies over the long run.
Yeah, indeed. Regarding the latest published studies, how do you think are distributed the two techniques in terms of indications for symptomatic carotid and for asymptomatic? How do you think are they distributed nowadays?
Well, it's clear that the newer therapies are going to be used more prominently, at least initially, in asymptomatic patients. But the most recent studies show quite an excellent balance. So, for example, another study cited in the PVI book is from a journal called Operative Neurosurgery. The author is Ramsay. And what they did is they looked in the US at what we call a national inpatient sample, which looks at a sampling of patients over a variety of different insurance programs, symptomatic and asymptomatic patients balanced. And they looked at CEA versus transfemoral stenting versus TCAR, or transcarotid
Mm,
artery revascularization, carotid stenting through a cervical approach with flow reversal. And what they
mm,
found is that CEA and TCAR had very, very similar perioperative risk and long-term patient outcomes, whereas transfemoral carotid stenting was not as good in terms of, in other words, the perioperative risk was higher with
mm.
transfemoral than it was with CEA or TCAR. And
Yeah,
again, this is with a balance between symptomatic and asymptomatic patients, or propensity matching in this, again, nationwide study. So this was 369,000 patients.
mm,
This was in the US, so not in the EU, but
yeah.
nevertheless, the patients were propensity matched and the operators were not vetted. So this is real world activity going on in communities as we speak.
Yeah, in unselected patients. I think it's important what you're saying with this, because with those nationwide studies, I mean, the technologies are advancing so fast that from the beginning of the study until the end, there probably have been some new technologies. And speaking of which, I think I can say with quite certainty that in Europe, I mean, in France, we don't use as much TCAR and flow reversing technologies as you do in the US. Instead, we use carotid embolic protection devices. And regarding all of those techniques, have you seen any technical advance in technologies that are made specifically to prevent strokes? Have you seen any recent advances in technology?
Yeah, there have been some advances, and I anticipate that we're a little bit on the edge of, or on the cusp of, substantial further advances. So let me just explain what I mean. Um, I'll go over the advances, but I think one of the things that is key is that if you look worldwide, uh, US, EU, but also worldwide, what you see is that in many countries, the use of CEA has plateaued or even decreased a little bit, whereas the use of transfemoral stenting, or all stenting technologies is actually increasing somewhat. There are lots of reasons for that. Some of it is new technology. So, for example, with regards to new technology, now we have the prospect of, several types of covered stents. Uh, Probably there's increased usage of covered stents, so we're starting to gain sort of longer term experience with the potential to use covered stents to try to make the perioperative period safer, possibly even the longer term. There's also, you mentioned flow reversal, so there are several different efforts, I should say several different companies that are using different types of flow reversal in clinical trials. So in the US, there's one established one, but there are two now, startup companies, or let's say earlier phase companies, maybe not correct to say startup, but earlier phase companies that have sponsored clinical trials and are, at least one of them is currently enrolling to look at different methods for flow reversal. And then in addition to those, I think one of the things that we've gained over these years is a healthy respect for who's a good candidate for each technology. So back when
Mm,
we had randomized trials, for example, when all we had was CEA and transfemoral stenting, we had this dramatic push to do randomized trials to compare these
mm.
therapies. What we didn't quite have a good sense of is who is a good candidate
Yeah, will
for a
benefit more.
stent.
Yeah. Mm,
Exactly. So we're getting a lot better at understanding who has maybe an arch that's has too much tortuosity or too much occlusive disease, too much calcification, or possibly great vessel tortuosity, or even a carotid bifurcation that has too much calcification. So one of the things that we're looking at in terms of new technology development is the potential to use intravascular lithotripsy or IVL to treat patients that have calcification at the carotid bifurcation that is prohibitive for stent placement. Now, I will say, just as a proviso, it's really early. There
Yeah.
have been no clear-cut, properly done trials. There's only been anecdotal usage, so I don't recommend it. But in terms of new technologies, I anticipate that we're going to learn a lot more about this in the coming year than we have known in the past. So
Yeah.
in any event, the combination of the new technologies and also the fact that worldwide, I think in many, many countries, we're looking at different ways, different methods by which carotid stenting could be made safer. So I anticipate continued growth in that area.
Yeah. Yeah. Keeping on with the stentings, we would like to have also your point of view on the technological developments such as the double layered mesh stents and active balloon for preventing restenosis and double layer mesh stents instead of cover stent. What do you think of have you seen any recent development in technology that is already in use today?
Well, in terms of the mesh covered stents, the concept is excellent. The idea that you could then potentially prevent any added embolization that could take place, between the struts of a stent during the perioperative period. The concept is excellent. Now, there have been a couple of efforts that have not worked out. One is one that I was involved in a couple of years back, which was a PTFE, so it was a partially mesh covered stent with a PTFE mesh. That the clinical trial, although the clinical results were acceptable, it did not appear to advance the effort. Nevertheless, there's been more recently the use of PET covered stent and also double layered with a very fine nitinol mesh. And I wouldn't say I cannot cite a specific paper that definitely proves these technologies, but what I see is that the doctors find this intuitive. So I see increased usage of these in many areas. I think it's only going to be a matter of time before we really understand what the perioperative risk and what the long-term benefits might be. One thing I would really like to see is additional data using DW MRI in the perioperative period with mesh covered versus bare metal stents. I think this would be extremely helpful. We don't have that quite yet, or at least not on a broad enough scale that we can say for sure that the mesh covered stent has a high value in terms of perioperative risk. But I know there's a lot of excitement around that. And like I said, I think most physicians find it intuitive that if you're going to stent the carotid bifurcation, the thing we worry about with carotid bifurcation is potential for embolization. So if you can reduce the potential for embolization by having a greater scaffold or mesh covering of the highly irregular heterogeneous bifurcation surface, then that would most likely lead to some benefit, some improvement.
Yeah, for sure. We will follow, I think, the results, the upcoming results about those new stents. And also, just to finish about this topic, with the broader application of carotid artery stenting, we start to see patients that have in-stent restenosis. And there are more and more of those patients. And regarding this specific issue, active balloon, like drug-coated balloons, what do you think of them? We start to have some evidence about their usage in these indications.
Yes, I think this is, again, talk about intuitive concepts, or at least those of us who are passionate about vascular care, we are looking for applications of, these types of things, how we can use drug-coated balloons to reduce the the long-term risk or to treat restenosis in different vascular beds. One thing we don't have with that, I know this has been done, the use of drug-coated balloons for in-stent carotid restenosis. I know it's been done. I know there are case reports, but we don't have a good prospective study. So we don't know its efficacy. We know that in-stent restenosis, that drug-coated balloons is used to treat it almost everywhere else it occurs in the
Yeah.
body, from coronary to lower
Femoral, yeah.
extremity, renal, iliac, everywhere we might have in-stent restenosis, we've used drug-coated balloons. So I personally, this is my own opinion, believe that it's only a matter of time before we have an indication in the carotids, but it's more challenging because you worry about, whereas the potential for particulate embolization from a
Embolization.
drug-coated balloon, I think we imagine that it almost always is going to be inconsequential in the muscles of the calf or in, other places, but we don't know about the brain.
Of course.
And so this will have to be studied. I don't think we
Yeah.
have a handle on this yet.
Sure. So we expect and we will wait for prospective studies evaluating the safety of drug-coated balloon in this indication. My last question, we would like to have your insight about something that has, in our experience, really changed our management of patients with carotid artery stenosis. It is plaque assessment. What do you think of it? Which indication for you is suitable, and has it really changed practice as we think it has for those patients?
Yeah, so I think that in symptomatic patients at the present time, I believe that that when patients present with a recent transient ischemic attack or stroke and a suspicious lesion, I think it's of academic interest for sure to look at the plaque, but the patient still has a strong indication for carotid bifurcation repair in addition to best medical management. But the vast majority of patients who present with carotid disease are not symptomatic. They're asymptomatic. And yet we know that every single patient who presents with a new stroke, they used to be asymptomatic. So if we could find those asymptomatic patients, so I think this concept has been out there for quite some time, that if we could understand the risky plaque morphology. So I'm right there with you, and I think a lot has been done with duplex, but I think now more often both CTA and MRA so are being really studied closely as a potential to look at plaque morphology and try to find high-risk plaque. So for example, there are a couple of technologies that have been developed mainly to look at coronary plaque risk that have now been expanded to carotid plaque risk. This is using CTA, and CTA is a common way to evaluate these patients because we're looking at potentially the anatomy of the carotid artery, its lesion, the surrounding area. We're trying to select therapy and see which patients have the best anatomy for which approach. But this same analysis of CTA can be used with additional software. So there are a couple of companies in the US, for example, that have software that do extremely finite analysis. It's almost like finite element analysis of the carotid bifurcation, looking at the lipid-rich necrotic core, how much calcification there is, how thick the calcification is, how much of the plaque is just fibrous, and how much of the plaque appears to be very, very soft, that is representing either recent hemorrhage or a liquid-like plaque. And of course, when you find those plaques with the high risk criteria, this is where I think if you're going to put a stent, flow reversal would be probably more beneficial. And if you're not going to put a stent, then CEA would probably be the answer for these extremely high risk plaques.
Wow, very interesting. Didn't know about those finite elements from the CT, and maybe maybe we will see how sensitive it is compared to MRI and everything. Well, we have to end this interview now, but it has been very interesting. And I would like to thank you so much for participating in this. And to everybody and to you, I will like to say that we'll have the pleasure to continue the discussion and to discuss so many other very exciting topics at the next PVI Congress in the Louvre in Paris in December. And also, we will also be able to see a lot of impactful and very important trials that you mentioned in the PVI Trials book. So thank you very much.
Very good.
And
thank you for inviting me.
Thank you very much.
See you in December.
Okay. Yeah.
Bye-bye.